Welcome to the second lecture of this ophthalmology module. And this lecture is on clinical examination in ophthalmology. And as you can understand that given today's examination scenario, clinical examination is very, very important. And there are lots of questions that can come from here. They can be conceptual, they can be image based. And actually in our UG curriculum, clinical examination in ophthalmology is not done in that much detail. So in this session, I will try to cover the clinical examination. So what are the topics we will be doing? We will be doing the different types of vision charts. We will be learning a little bit about slit lamp biomicroscopy, that is the anterior segment evaluation. And we will be talking about direct and indirect ophthalmoscopy. Okay, so shall we start? So see, when we talk about a patient who is coming to an ophthalmology OPD, what is the main complaint that the patient has most of the time? Most of the time, the patient's difficulty is that he has a problem in seeing, right? He says that he's not able to see properly. So there's a problem in vision. Now, when the patient comes to us and says that he has a problem in vision, the first thing that we do is we have to do a functional assessment. So, examination is functional assessment. That is when a person says that he or she is not able to see. So, we have to do a functional assessment, which is a vision assessment, which tells us that how much the vision is compromised, and also another thing, that is which component of the vision is compromised. So what do we mean by vision assessment? Now vision assessment has these four components, that is visual acuity, contrast sensitivity, color vision and field of vision. So, see, these are largely conceptual. There is very little to memorize from here, but a lot to understand. So, I try to tell you what we mean by visual acuity. So, if I put it in very, very simple terms, see, the smaller an object, the more difficult it is to see. So, if an object is large, then even a person with not so good visual acuity will be able to see and appreciate the details of that particular object. But if you have a very small object, then in order to look at that, identify that object, appreciate the details of the object, you need to have better visual acuity, right? So this is what we mean by visual acuity. Next, what is contrast sensitivity? Contrast sensitivity means that suppose I draw this kind of a black line on this white background. It is easy to appreciate this line. But suppose I draw this kind of a line, this line on this, a faint yellowish line on this white background, that is more difficult to appreciate. So a person with a good contrast sensitivity will be able to appreciate this line. But a person with not so good contrast sensitivity also will be able to appreciate a black line on a white background, right? Because the brightness of these two is very, very different. So a black line on a white background is easy to appreciate. There is a hard or a strong contrast there. But if you put a faint yellow line on a white background, that is more difficult to appreciate. So how good is your ability to identify this? That is what we mean by contrast sensitivity, right? Now color vision. Obviously all of you know what is color vision. Color vision means the ability to appreciate mainly the three primary colors and their variants. And the field of vision. Now what is field of vision? This is also another important component of vision. That is, suppose I am looking straight at an object. Apart from that particular object, which is my object of interest, a lot of things in the periphery are visible to me. That is my field of vision. So you understand each component of vision is actually important. So when a person comes to us and says that I am not able to see or I have difficulties in seeing, then it may mean any of this. It may mean that there is a problem in visual acuity, in contrast, in color vision, or even the field of vision. So this functional assessment actually includes all of this. Now these are not definitions which I told you. This is just for us to understand because that is what is important in this chapter, right? So I hope now you have understood what we mean by functional assessment. Next is, once we have completed the functional assessment, that is, we have understood which component of this vision is actually affected and how much it is affected, next comes your structural assessment. That is, you have to evaluate the anterior segment and the posterior segment to see which of the ocular structures are normal, which structure is abnormal and which is responsible for this decrease in vision. So that is your structural assessment. Okay, so first I will come to the functional, that is the vision assessment, and we will try to go over these components. Now commonly, those of you who have gone for eye checkups or those of you who have attended your OPD postings, you will see that the first test that we do is actually the test for visual acuity. That is the commonest component of vision that we check. We should actually be checking all the others also, but in a busy OPD may not be possible to do everything, so we always do the visual acuity first. So the visual acuity chart, the commonest chart is this. This many of you would have seen in your OPD postings. This is the Snellen's chart, which is the visual acuity chart, which is the most commonly used visual acuity chart in our OPD. So see, I told you what is visual acuity in very simple terms. It means that if an object is large, it is easy to identify the object and appreciate its details, but if it is small, it is difficult to appreciate its details. So that is the same principle is actually applied to the Snellen's chart. So look at this chart. See, the letters are gradually becoming smaller as you move down the chart. Okay, so if we get this as an image-based question, how will you identify this chart? See, the letters become smaller as you move down, and also please remember the number of letters in each line increases as you move down. So the number of letters in each line increases as you move down. So see, the first line has 1 letter, and the second line has 2 letters, the third line has 3 letters, and so on. So as you move down, the number of letters also increases. So this is the way to identify this as an image-based question. The size of the letters decreases as you go down, and the number of letters in each line increases as you go down. Now, when you check the person's visual acuity by Snellen's chart, we have to do it uniocularly. You make the patient wear the trial frame, occlude one eye, and ask him or her to read with the other eye. Now, what is the distance at which the person has to read this chart? The standard reading distance is 6 meters or 20 feet. The standard distance is 6 meters or 20 feet. But if the length of the room is not 6 meters, it's very difficult to have a 6-meter room. So we usually what we have is we have a 3-meter room with a mirror. So it gets converted to a 6-meter room. So it's a 3-meter room with a mirror so that it becomes converted to a 6-meter room. Now this is the very basic chart. But nowadays, we have smart charts which can be adjusted to any distance. So just like we have smartphones, we have smart charts also, and they can be adjusted according to the size of your examination room. But for exam, we have to remember standard reading distance for Snellen's chart is 6 meters or 20 feet. Now, as I told you, make the patient wear the trial frame, occlude one eye, ask him to or her to read with the other eye. Now, if the patient reads the topmost letter of the Snellen's chart, then the visual acuity is denoted as 6 by 60. So this is what we say if the person is able to read the topmost letter. Now, what do we mean when we say that the visual acuity is 6 by 60? Please listen to this carefully. This means that this letter is big enough to be read from a distance of 60 meters. So ideally, a normal person will be able to read this from a distance of 60 meters, but the patient is reading it from a distance of 6 meters. That is what this means when you write 6 by 60. This is a way of representing. Now, what does 6 by 60 mean? I'll repeat it once more. It means that this letter is visible to a normal person from a distance of 60 meters, and the patient is reading it from a distance of 6 meters. Right? Suppose the person is reading the second line, then how do you denote it? This is written as 6 by 36. If the person reads the third line, then it is 6 by 24. If the person reads the next line, we call it 6 by 18. Then if he reads the next line, it is 6 by 12. Then if he reads the next line, we call it 6 by 9. And then if he reads the next line, that is 6 by 6. 6 by 6 is also called as 20 by 20. And this is the normal visual acuity. So first line is 6 by 60. Second line, if the patient reads 636, 624, 618, 612, 69. Now see, what does 6 by 36 mean? Again the same thing. It means that these letters are big enough to be read from a distance of 36 meters. But the patient is reading it from a distance of 6 meters. Same, then 624, 618, 612, 69 and 6 by 6. Now you can understand why 6 by 6 is called as normal visual acuity. Because 6 by 6 or 20 by 20 means what? It means that this letter should be read from a distance of 6 meters and the patient is reading it from a distance of 6 meters. So it's normal. Same, 20 by 20 means that it should be read from a distance of 20 feet and the patient is reading it from a distance of 20 feet. Okay, so this is how visual acuity is evaluated with the help of the Snellen's chart. So if the person reads the first line correctly, 6 by 60. Second line correctly, 6 by 36. Third line correctly, 6 by 24. Fourth line, 6 by 18. Then 6 by 12, 6 by 9, 6 by 6 or 20 by 20. This is the normal visual acuity. Now if he reads the letters which are smaller than 6 by 6, then it is better than normal, but we don't make the patient read those charts. But there are smaller letters also. So beyond 6 by 6 also some smaller lines are there. If the patient reads that, that means it's even better than normal. Okay, now this much is conceptual. Now there is something which you have to memorize, and that is this part. Now if a person is suppose reading this letter from a distance of 6 meters. Now suppose this is if a person's visual acuity is, for example, 6 by 6. Right? Now this is a letter on the 6 by 6 line. Now suppose this is a letter on the 6 by 6 line. This is a letter on 6 by 6 line. Then this means that this entire letter is subtending 5 minutes of arc at the center of the eye. Now if a person's visual acuity is 6 by 6, this means that every letter on this 6 by 6 line is subtending an angle of 5 minutes of arc at the center of the eye, and see each part of the letter is subtending 1 minute of arc at the center of the eye. Only then the visual acuity will be 6 by 6. So for a letter to be visible to a patient, so suppose somebody's visual acuity is 6 by 6 and we are testing it from the standard distance of 6 meters, then every letter on that 6 by 6 line is going to subtend an angle of 5 minutes of arc at the center of his eye, and every part of the letter, see the whole letter is subtending 5 minutes and each part of the letter is subtending 1 minute of arc at the center of his eye, and that is why he or she is able to identify the letter. Okay, so I'll just repeat this once more. This comes as an MCQ. If a person's visual acuity is 6 by 6, then every letter on the 6 by 6 line subtends an angle of 5 minutes of arc at the center of the eye, and each part of the letter subtends 1 minute of arc at the center of the eye. Okay, now we have talked about the visual acuity of a patient starting from 6 by 60. That is, we have asked the patient to start reading and he or she suppose just reads the topmost line. Then we say it is 6 by 60. Now what do we do if the patient says that he is not able to see that topmost line? It is possible the visual acuity is even less than that, correct? So if a person's visual acuity is less than 6 by 60, meaning he or she is not able to read the 6 by 60 line also, then what do we do? Now less than 6 by 60, what are the ways to denote the visual acuity? This is counting fingers at 3 meters. Counting fingers at 3 meters. That is, you ask the patient to count fingers at a distance of 3 meters. So usually the room that we have, I told you it's a 3-meter room with a mirror. So if you stand at the end of the room and the patient is able to count the fingers, then that is called as counting fingers at 3 meters. That is less than 6 by 60. I'm just telling you in gradation what comes after 6 by 60. So just less than 6 by 60, we denote it as counting fingers at 3 meters. It is also written as 3 by 60. 3 by 60 means what? That ideally a patient should be able, a normal person should be able to count fingers from a distance of 60 meters. But this patient is doing it from a distance of 3 meters. So we write it as 3 by 60. So less than 6 by 60, the visual acuity, the next level is 3 by 60. Now what is less than 3 by 60? Counting fingers at 3 meters. Less than that is counting fingers at 2 meters. Now counting fingers at 2 meters is denoted by 2 by 60. Now what is less than counting fingers at 2 meters? Less than counting fingers at 2 meters is counting fingers at 1 meter, and that is denoted by 1 by 60. Now what comes less than 1 by 60? Patient not being able to count fingers at 1 meter, counting fingers close to face. That is, we put the fingers very close to the face and ask the patient to count the fingers. This is denoted as CF, counting fingers close to face. Now what is less than this? Less than this is, if the patient is not counting fingers close to face, less than that would be hand movements close to face. Hand movements close to face means we just move the hand in front of the face. If the patient is able to identify that there is something moving, then we denote the visual acuity as HMCF. Now less than hand movements close to face is projection of rays. Now projection of rays means that light is projected from different directions. So, see, this eye is occluded, you project the light from above, from down, medially, laterally. Ask the patient to point with the finger what is the direction from which the light is coming. If that is done correctly, then the visual acuity is denoted as PR, meaning projection of rays. Now, if projection of rays is also defective, then the next level is perception of light. Perception of light means we put light in the patient's eye and we ask whether he knows that there is light or there is no light. So if he is able to identify correctly when light is present or absent, we will say that perception of light is present. It is denoted as PL. Now if this is also defective, then that is called as no perception of light, and that is complete or absolute blindness. No perception of light, that is denoted as no PL. And this is like complete or absolute blindness. Right? So less than 6 by 60, what are the different levels of visual acuity less than 6 by 60? So in this we learned what are the levels of visual acuity more than 6 by 60. That is more than 6 by 60 will be 6 by 36, 624, 618, etc. Right? Now less than 6 by 60, what are the levels of visual acuity? Less than 6 by 60, the levels of visual acuity are 3 by 60. That is counting fingers at 3 meters, 2 by 60, 1 by 60. Less than that is counting fingers close to face. If that is also defective, the next level below that is hand movements close to face. If a person's hand movements close to face is also difficult, the next level below that is projection of rays. That is, the patient is able to say correctly what is the direction from which rays are being projected. If that is also defective, then the next level is perception of light. That the patient knows whether light is present or it is not present. And the last level, when even that is defective, we will say that no PL or no perception of light, which is complete or absolute blindness. Okay, so this is one of the ways in which visual acuity is assessed with the help of the Snellen's chart that you will commonly see in our OPD, because that's the chart most of us are using. Now, this you can see, these are letters. Now, what do we do for a patient, for a person who is not able to read? Now, for a person who is not able to read, there is another chart which is based on the same principle, just like this, looks just like this, just that the letters are replaced by C. This is called as the C chart or the Landolt chart. So see, instead of the letters, we have this C, and the patient has to, same, the size of the letters decreases as you go down, and the number of letters in each line also increases as you go down. Looks like the Snellen's chart only the letters are replaced by these C. So here the patient has to tell us where is that the mouth of the C open. So you have to ask the patient to point out with the fingers where there is up, where the right, left, down, oblique. So that is how we check for the visual acuity. This is called as the Landau's chart. This is used in case of illiterate patients, that is patients who cannot read. And a variant of the C chart is present, which is called as the E chart, where instead of the C chart we have E like this. The same way the patient has to tell us in what direction the E is pointing, whether it is pointing up, to the side, down, up. So that is also used for illiterate patients. So you can have the Landolt C chart or a variant that is the E chart. Okay, so all these are very similar to your Snellen's chart, which, as I told you, commonly you will see being used in OPDs in most medical colleges. Now, this Snellen's chart, though it is commonly used, it has some problems. Now, what are the problems? One of the main problems that it has is the way in which the visual acuity is expressed. That is, see, we are expressing it in terms of fractions, right? So it is expressed in in these fractions, and if also, see, there is the value has been given not to a particular letter but to the whole line. So suppose there is a patient who is reading maybe 1 or 2 letters of a line. For example, suppose there is a patient who is reading, say, 2 letters here, 2 of these letters, but he or she is not reading the rest of the letters. Now it's very difficult to express this in the Snellen's chart. Suppose he is reading 2-3 letters of the 2 letters of the 6 by 18 line. How am I supposed to express it? Am I supposed to call it 618 or am I supposed to call it 6 by 24? So when you are doing a scientific evaluation, then it becomes very, very difficult. That is, suppose I have checked the visual acuity of a patient prior to a procedure and I am checking it after a procedure. So if the patient has improved only by a few letters, then I may not be able to pick that up on the Snellen's chart, because here the value has been given to that entire line, not to those individual letters. So it's difficult to quantify improvement or worsening on the Snellen's chart when you are doing a scientific study. That is one problem. Another problem is that in the Snellen's chart, as you move down, see there is a crowding of the letters at the bottom, which is also a little bit troublesome for patients. So there is a crowding of letters at the bottom, and it is the way the visual acuity is denoted. It is denoted in this like 6 by 60, 6 by 36, and also the value is given to the whole line, not to a letter. So it may not be very suitable when you are doing a scientific study. So therefore, we have another visual acuity chart. And what is the name of that chart? See, the name of this chart is this. This is this chart. This is called as the ETDRS chart. Now, why it is called as the ETDRS chart is, ETDRS stands for Early Treatment Diabetic Retinopathy Study. Early Treatment Diabetic Retinopathy Study. So it was used in this study, and hence the name, right? So it is commonly referred to as the ETDRS chart, but the actual name of this chart is Bailey and Lovey chart. It is actually, the actual name is Bailey and Lovey chart, but because it was used in this ETDRS, that is Early Treatment Diabetic Retinopathy Study, that's why it is called as the ETDRS chart. Now, this is also a visual acuity chart. Now, if you get this image in the exam, how are you going to differentiate it from the Snellen's chart? See, here also the size of the letters is decreasing as you go down, and that's why, see, it's a visual acuity chart. In a visual acuity chart, the size of the letters will decrease as you go down. So here also the same thing is happening. But unlike the Snellen's chart, see, number of letters in each line is the same. There are 5 letters in each line. So number of letters in each line is the same. So there is no crowding at the bottom of the chart. So one of the problems of the Snellen's chart, I told you, was because more letters are there at the bottom, the chart starts becoming crowded, and it is a little troublesome for the patients. So that problem was solved by this. There are 5 letters in each line. Right? Now the next thing is, this chart, this is read from a distance of 4 meters. This is read from a 4 meter distance. And unlike the Snellen's chart, where, see, the notation was 6 by 60, 6 by 36, here it is expressed, the visual acuity is expressed in log MAR units. MAR stands for minimum angle of resolution. So it is expressed in log MAR units. MAR stands for minimum angle of resolution. To be a little more simple, see, because it is expressed in log units, it is easy to add and subtract. See, log units are easy to add, easy to subtract, so easy to quantify. So that way, see, it is expressed in log units, and also there is a value which is given assigned to each letter. So there is a value which is assigned to each letter, not to each line, not just to each line, but every letter has been assigned a value. So therefore, it becomes, suppose there is an improvement by just 2 letters, that can be quantified here, which was not being possible in the Snellen's chart. So because it is expressed in log units, it is easier to be used in calculations, and because there is a value which is assigned to every letter and not just every line, it becomes very easier to quantify. So that is why this chart is more useful when you are doing a scientific study. So suppose I am doing a scientific study where I am checking where I am trying to evaluate how much is the improvement of visual acuity after a certain procedure has been done or after a certain drug has been given. It is easy if I do it with this chart, because see, as I told you, every letter, if there is an improvement by even 1 or 2 letters, it can be quantified here. And secondly, because the visual acuity is expressed in log units, it is easier in calculations. Okay, so this is the second chart, that is second visual acuity chart, that is the ETDRS chart, right? So this much about visual acuity, which is the first and perhaps the most important component of vision assessment. Now, visual acuity is, as I told you, see, the big letters are easier to see, that is big objects are easy to see, their details can be easily identified, but smaller objects, smaller letters are difficult to identify. That is the basic principle of evaluating visual acuity. Right? Now, what is the next component of vision I told you? The next component of vision is contrast sensitivity. Contrast sensitivity. Okay, but before I go on to contrast sensitivity, one more small thing I'll just tell you, that when we are evaluating the visual acuity of a patient, and if the visual acuity is less than 6 by 6, what are we supposed to do? The next thing you're supposed to do, if the visual acuity is less than normal, what you're going to do next is, you're going to put this pinhole in front of the patient's eye and ask him to read again. So you evaluate the visual acuity without normally first, and if it is less than 6 by 6, then evaluate it again with the pinhole. Now what is the pinhole? Now this pinhole, it has a small aperture at the center which is about 1 mm. And what it does is that it cuts off all the paraxial rays and just allows only the central rays to pass through. And what does an improvement in visual acuity indicate with pinhole indicate? This is very, very important. Now, whenever there is an improvement in visual acuity with a pinhole, this indicates that there is a refractive error. Now, this is very, very important because see, a large percentage of patients in our OPD, their difficulty in vision is because of refractive error. So, suppose somebody's visual acuity is say 6/36. And suppose after putting the pinhole, we denote it like this, with pinhole, suppose it improves to 6/6. So see, the visual acuity was 6/36, but it has improved to 6/6 with pinhole. This indicates that there is a refractive error. So what is the first thing I have to do for this patient? I reasonably know that what is the cause. Even before examining anything else, I reasonably know that the cause of this decreased visual acuity is a refractive error. So I need to do a proper refraction for this patient and give him a good glass prescription. So when there is a decreased visual acuity, the next thing, the simplest thing that you do next is you put a pinhole and check the visual acuity again. If the visual acuity improves, that means that there is a refractive error which needs to be corrected. But suppose the visual acuity does not improve. That is, the visual acuity is 6/36. And suppose with pinhole also there is no improvement, meaning it is 6/36 with pinhole also. If there is no improvement, this generally means that there is an ocular pathology. Like for example, suppose there is a cataract. If there is a cataract, if there is some other pathology, then no change in visual acuity with pinhole means that it is not because of a refractive error. There is some organic pathology. That means you have to do a proper structural examination for this patient. Okay, so these two things are very, very, very important clinically. So when there is a patient whose visual acuity is less, you put a pinhole. If the visual acuity improves with pinhole, you have a simple diagnosis in hand. It means that it's a refractive error which needs to be corrected. But if it doesn't improve, that means that it's not a refractive error. There is some organic pathology. It may be a cataract, it may be something else. But that means that the pathology is an organic pathology. It's not a refractive error. Okay, so this actually completes our visual acuity assessment, and now we can move on to the next one which I was saying, that is the contrast sensitivity. Now as I told you in simple terms, if I have to explain what is contrast sensitivity, I told you, see, I am writing with this black pen on this white background and this is easy for you to read, but suppose I wrote with this yellow, it may not be that easy. Right? So this difference in brightness makes it easy for us to identify things. So look at this chart. The name of this chart is Pelly-Robson chart, and this is used to evaluate contrast sensitivity. Now you can get this as an image-based question. You can get this chart and you may be asked what is the name, what is this used for. So how do you identify this chart? See, the size of all the letters here are the same. So it is not a visual acuity chart. In a visual acuity chart, the size of the letters will decrease. Here the size of the letters is not decreasing. But what is decreasing? The brightness of the letters, right? So as you move forward, the letters, they become fainter. The letters, they become fainter. So you can understand that the first letters are much, much brighter. They are easy to identify. But as you move further, see, look at these last letters, very, very faint. So very difficult to identify. So a person with a good contrast sensitivity will be able to identify the last letters. So then you know that the contrast sensitivity is good. So this is read from a standard distance of 1 meter. And they are actually triplets of letters. These three letters have the same contrast. So there are triplets of letters and the patient and the contrast of each triplet decreases as you move forward. So there are triplets of letters. So these three letters have the same contrast sensitivity. Then the next three letters have the same contrast sensitivity. So you ask the patient to read and each triplet has a value. Value is assigned to each triplet. Value is assigned to each triplet. So see, the earlier triplet is much brighter, it is easier to identify, and as you move forward they become much, much fainter. So this is another component of vision. So where do you think contrast sensitivity is affected? See, contrast sensitivity is affected in diseases like cataract. Right? So therefore, when a patient says that he's not very comfortable when the light is dim or at night, it is possible that his contrast sensitivity is affected and he may be having a cataract. So sometimes when a patient says that I am not able to see properly, it doesn't always mean that it is visual acuity is only affected. It may be his contrast. So it is important that when we do a vision assessment, we don't check only the visual acuity, we should also check the other components. Okay, so I'll just repeat this. Contrast sensitivity chart is the Pelly-Robson chart. Standard reading distance is 1 meter. All the letters are of the same size, but the letters become fainter as we move forward. So there are triplets of letters and each triplet is assigned a value. So the top letters are much sharper, whereas as you move down, the contrast decreases. So only a person with a very good contrast sensitivity will be able to read the lower letters. Okay, this is the second aspect of vision assessment. Third aspect is color vision. Now the color vision, this is assessed by this chart which is called as the Ishihara's chart. Now this is very easy to identify if you get this in the form of an image-based question. See multiple colors. So we ask, this is read from a standard reading distance. This is read from a standard reading distance, and this helps you to identify. See, there are certain numbers or patterns which are visible. So only a person with a proper color vision will be able to identify the pattern or the letter which is written. Okay, so this Ishihara chart, it helps to identify red-green color vision deficiency. Red-green color deficiencies are identified with this chart. They are actually the common color deficiencies red-green only. So that is why this is used mainly for screening purposes. Right? Now, where is exactly color vision important? Color vision is particularly important in certain professions. For example, for people who drive trains, for pilots, for certain other professions where the perception of red and green is very critical to their job. So this is of particular importance when we are giving fitness certificate for employment for these kind of professions. So in that, the screening chart that we use is this because it tells us about red-green color vision deficiency. It is read from a standard reading distance. It has got usually about 38 plates, and we ask the patient to either read the letter or identify the pattern which is given, and only a person with a proper color perception will be able to do that correctly. Now for exam, you have to know the names of a few other color vision tests. Now these are asked, you don't have to go into the details, but I just want you to know the names. These are the other color vision tests available: Holmgren's wool test, lantern test, Farnsworth-Mansell D15 test, Needle's anomaliscope. Now this is important because your Ishihara is telling you only red-green color deficiency. So if we have to identify others, then these tests are actually more useful in that regard, because Ishihara is a screening tool, help you to identify red-green, but for others we have to learn up the names of these: Holmgren's wool test, lantern test, Farnsworth-Mansell D15 and Needle's anomaliscope. Now a few other things which I feel you should memorize about color vision. Now see, color vision is a function of the cones, and so it is best appreciated in photopic conditions. The center of the fovea is blue blind, and trichromatic color vision extends up to around 30 degrees of fixation. This is a function of the X type of ganglion cells of the retina. We will be learning about the ganglion cells in the anatomy of retina. And the parvocellular part of the LGB. LGB stands for lateral geniculate body, which is a part of the visual pathway. That also we will be learning in neuroophthalmology. So the parvocellular part of the LGB is involved. All these are asked as one-liners. So please memorize this, that it's a function of the cones. The X type of ganglion cells and the parvocellular part of the LGB are involved in this. Trichromatic color vision extends up to around 30 degrees of fixation, and the center of the fovea is blue blind. Okay, now when we talk about color vision deficiencies, we can have congenital color vision deficiency, we can also have acquired color vision defects. Now congenital color vision deficiency, the inheritance pattern is X-linked recessive, and therefore it is seen in males. So it is seen in males. What are the different types? There is achromatopsia. There is something called as achromatopsia, meaning that there is no color perception because the cones are completely absent. Then you have something called as monochromacy, meaning there is appreciation of only one primary color. Then dichromacy. Dichromacy means that two primary colors are appreciated and the third one is not appreciated. And this is again subdivided into protanopia, which means red color is not perceived, deuteranopia, which means green is not perceived, and tritanopia, which means blue is not perceived. So here see, two colors are appreciated and one color is not appreciated. So depending on which of the colors is not appreciated, we divide it into three types, that is protanopia, deuteranopia and tritanopia. So here two colors are appreciated and one color is not appreciated. And the last one is what is called as trichromacy, meaning all the three colors are appreciated, but one of the colors is a little bit defective. So it's not like that the color is not appreciated, but it is defective. So depending on which is the color that is defective, see here we have protanomelie. So protanomelie meaning red color appreciation is defective. Similarly, deuteranomelie and tritanomelie. So these are the different types of congenital color vision deficiencies that can happen. Then acquired. Acquired color vision deficiencies can be either red-green deficiencies or blue-yellow deficiencies. Now red-green deficiencies, they are seen in optic nerve disorders. This is very important for exam. Red-green color deficiencies are seen in optic nerve disorders except for glaucoma. So glaucoma is also an optic neuropathy. But it does not have red-green deficiency. It has blue deficiency, and blue deficiency is seen in macular disorders and glaucoma. So which is the only optic nerve disorder which presents with blue deficiency? This is glaucoma. Otherwise, optic nerve disorders like for example optic neuritis, there will be red-green deficiency. But only in glaucoma it is a blue deficiency. Otherwise, blue deficiency is seen in macular disorders. Okay, so this is about our acquired color vision defects. So see, what have we learned? We have learned how to evaluate visual acuity, contrast sensitivity and color vision. The last is field of vision. Now field of vision is evaluated by perimetry. Perimetry means evaluation of visual field. Now perimetry we will be discussing in detail in the chapter on glaucoma, because glaucoma is essentially a disease where there is a loss of peripheral visual field. So perimetry I will be discussing in detail in the chapter on glaucoma. So in this chapter, as I told you, I have discussed the important vision charts that you must know. So see, all of them can come, they can come as conceptual questions, they can come as image-based questions. So we discussed about Snellen's chart, Landau's chart and ETDRS chart, which are the visual acuity charts. We discussed about the Pelly-Robson chart, which is the contrast sensitivity chart, the Ishihara's chart, which is your color vision chart, and also the other color vision tests. Right? So this much is about our functional assessment. So as I told you, when a patient comes to us and says, I am not able to see, we have to do this complete vision assessment, that is visual acuity, contrast sensitivity, color vision and field of vision, to be able to understand which component of his vision is affected and how much it is affected. Right? Now once we have done that, the next step is what? The next step is your clinical examination for structure, that is structural evaluation. Now we are trying to see which is the structure in the eye which is defective, which is giving rise to this vision problem. Right? So now when I talk about structural assessment, we divide it broadly into anterior segment evaluation and posterior segment evaluation. Now just to quickly recap from what I told you in our first session, what is the anterior segment? All the structures in front of and including the crystalline lens, that comes in our anterior segment. So this crystalline lens is dividing the eyeball into two parts. Everything in front of the crystalline lens, including the crystalline lens, comes in our anterior segment, and the structures behind the crystalline lens, they come in the posterior segment. Okay. Now for anterior segment evaluation, we use this instrument. This is the most basic instrument in an ophthalmopedy, and this is called as your slit lamp biomicroscope. This is called as the slit lamp biomicroscope. Now see, I'll just broadly tell you how this instrument is used. So if you look here, this is called as the chin rest. Now the patient sits on that side of the slit lamp and puts his chin on the chin rest. Now this is the eyepiece. Now this is the eyepiece, and through this eyepiece, the examiner evaluates. And here, this is your illumination system. This is the illumination. This is from where the light is coming. This is from where the light is coming. So the chin rest is the place where the patient is keeping the chin. Through the eyepiece, the examiner is looking, and through that illumination system, the light is coming, so that you will be able to see the structures. Right? So this slit lamp, what does this help us to evaluate? So basically this slit lamp, it helps us to evaluate the external structures. First of all, so what are our external structures? The external structures, like for example, external structures like the lids, the conjunctiva, lacrimal sac area, etc. So we can look at the eyelids, we can look at the conjunctiva, we look at this area, that is the lacrimal sac area. So this gross examination, it helps us. Next, it helps us to evaluate the anterior segment of the eye. It helps us to evaluate the anterior segment of the eye. So all the structures including in front of and including the crystalline lens. Now it also helps us, we can see up to the anterior 1/3 of the vitreous cavity. It helps, you can see up to the anterior 1/3 of the vitreous cavity. So you can see the external structures, you can see the anterior segment, you can see up to the anterior 1/3 of the vitreous cavity, and you can also see here to this slit lamp, see this structure is attached. What is this? This is called as the Goldman applanation tonometer. So this structure which is attached to the slit lamp, this is called as your Goldman applanation tonometer. And what does this help to do? This Goldman applanation tonometer, it is going to help us in evaluation of intraocular pressure, that is IOP evaluation. Intraocular pressure, that is IOP evaluation. So all this can be done on your slit lamp. So see, when I look through the slit lamp, this slit lamp, as I told you, it is mainly for evaluation of your anterior segment. So it will help me to get a gross view of the anterior, of the external structures, that is the eyelids, the conjunctiva, the sac area, etc. It is going to help me to see all the structures in the anterior segment. It also gives me a view of the anterior 1/3 of the vitreous cavity, and to this is attached this Goldman applanation tonometer, which will help me in IOP evaluation. Okay, now let me tell you that how is this slit lamp useful to us. So see, in the slit lamp, what you can get is, you can get a diffuse view like this. So if I just put on the slit lamp, first of all what I will get is a diffuse view. Now what is a diffuse view? This diffuse view is nothing but a magnified torchlight view. A magnified torchlight view. It is very similar to a torchlight view, but it is magnified. So if I put a torch in the eye also, I will be able to see all the structures, these external structures, but they will be obviously small. When I look through the slit lamp, I put on the diffuse illumination or the diffuse view, I will be able to see all the structures, but in a magnified fashion. So it is nothing but a magnified torchlight view. But that is not why I want to use the slit lamp. See, when we did the codes and contents of the eyeball in the first session, I told you that if you want to look at the structures, you had to create a cross section. Only then you will be able to study the structure, right? So that's why when we wanted to learn the codes and contents of the eyeball, we made a sagittal section and we looked at the eyeball from the side. So until and unless we create a cross section, we will not be able to study the individual structures. So that is what this slit lamp is giving us. It gives us an optical slit view. So this is your cross sectional or your slit view. So look at this cross sectional view. It is creating an optical cross section. So see this outermost slit that you see, this one, this is your cornea. I hope you can see that this outermost slit, this is the cornea. This is your crystalline lens. This is the crystalline lens. Now see this brown thing in the periphery, this is your iris. This is the iris. And this black area here, this is your anterior chamber. This is the anterior chamber where you have the aqueous humor. Okay, so basically this little view, this slit lamp, it is very, very important because it is giving me this optical cross section. So that outermost slit, that is the cornea, then I can see the slit of the lens, I can see the iris, I can see the anterior chamber. So now when I get this kind of a cross sectional view, I will be able to see if there is a pathology in any of these structures. Suppose there is a corneal opacity, I will be able to pick up that corneal opacity, the location, the depth. Similarly, if there is a lens opacity, cataract, I will be able to pick it up. If there are cells in anterior chamber, I will be able to pick it up. So this slit view or this cross-sectional examination, optical cross-section that we get, this is what helps us to evaluate the anterior segment with the help of the slit lamp. Okay, so this is the structural examination of your anterior segment, right? Now how about the posterior segment? See, this slit lamp is allowing me to view only up to the anterior 1/3 of the vitreous cavity. But if I want to complete my examination, I have to evaluate the posterior part of the vitreous cavity and I also have to evaluate the retina. Only then my posterior segment evaluation will be complete. So how do you do that? There are different methods of doing that. One of the methods is, now see in the slit lamp, see in this picture only of the slit lamp, you see that there is a small lens which is kept here. Now this lens, this is called as a 90 diopter lens. What is this called? This is called as a 90 diopter lens. Now if you place this 90 diopter lens in front of the patient's eye, if the patient is sitting on the slit lamp and in addition to the slit lamp, if you place this 90 diopter lens in front of the patient's eye, you will be able to see the posterior segment. So that is one of the ways of evaluating the posterior segment. So for posterior segment evaluation, one option is this, that is you make the patient sit on the slit lamp and you place a 90 diopter lens in front of the patient's eye. So the patient was anyway sitting on the slit lamp because I was evaluating the anterior segment. You just pick up this 90 lens and place it in front of his eye and you will get a view of the posterior segment. But this method, it has its limitations because it allows us to view only the central part of the retina. You cannot see it, you can get a good view of the central retina, but it is difficult to examine the peripheral retina. So by this method, you can examine the central retina, but in this, it is difficult to examine the peripheral part of the retina with the help of a slit lamp and 90D. It is easy because the patient was anyway sitting on the slit lamp. You had already evaluated the anterior segment, just pick up the lens, put it in front and see the posterior segment. You will be able to see and evaluate the central part of it very well, but the periphery of the retina is difficult to examine on your slit lamp by a microscope with 90D. Now there are other methods also of posterior segment evaluation, and that is this. That is the direct and the indirect ophthalmoscopy. Now before I go there, I will just quickly show you this picture of, this is a picture of the retina. We will be doing it in detail in the chapter on retina, but just for you to get an idea about what I mean by central, what I mean by peripheral. See, this is the retina. This structure that you see here, this is your optic disc, which is the beginning of your optic nerve. Now these are the blood vessels of the retina. These are the retinal blood vessels. Now see, these are the vascular arcades. Now between the vascular arcades, this entire area that you see, this is the central part of the retina and it is very important for vision and it is called as the macula. And the centermost point of the macula here, this is the most important area for vision, and I think all of you know what this is called. This is called as your fovea. Okay, so this disc macula, this part is called as your central retina, and beyond the vascular arcade, see all these parts, this is your peripheral retina. This is the peripheral retina. Beyond the vascular arcades, this part within the vascular arcades, that is the disc, the macula, this part is called as the central retina, and beyond that the peripheral part of the retina is there. So when I say that I am looking at the central retina, I essentially mean that I am looking at the disc and the macula, the central structures. And peripheral retina means beyond the vascular arcades, the periphery, that is your peripheral retina. Now, as I told you, with a slit lamp microscope, the central retina can be examined well, but it's difficult to examine the peripheral retina with your slit lamp and 90D lens. Now, what are the other instruments that we have? As I told you, we have the direct ophthalmoscope and we have the indirect ophthalmoscope. Now, this is a question traditionally very, very, very important for exam. So, these are the two instruments. The first one here, this is your direct ophthalmoscope. This is your DO, which is the direct ophthalmoscope. How do we identify this? See, there is a handle. On top of the handle, there is a head, and also there is a dial here at the side. Right? So how do you use this instrument? You hold the instrument in your hand, you go close to the patient, you rotate this dial to focus the retina. So we hold the instrument in the hand, we go close to the patient, rotate the dial and we focus the retina. Right? Now with this, the examiner can use only one eye. So because I have to see only with one of my eyes, I cannot use both my eyes for examination, right? Now the other instrument is your indirect ophthalmoscope. So this is your IDO. This is called as the IO or the IDO, indirect ophthalmoscope. Now this instrument, this is worn on the head. The examiner wears this on the head, and in the hand the examiner has to use another lens which is called as the 20 diopter lens. So see, with your slit lamp you use the 90 diopter lens. Here we have to use an additional lens called the 20 diopter lens, and that lens is used to focus the retina. And here the examiner can use both his or her eyes. So this is an instrument which is binocular for the examiner, meaning I wear the instrument on my head, I am using both my eyes for examination, and I will use an additional lens called 20 diopter lens to focus the retina. So let me just go through the procedure once more. The direct ophthalmoscope, it has a handle and a head and it has a dial at the side. I have to hold the instrument in my hand. I have to go close to the patient and I have to rotate that dial to focus the retina. But I can use only one of my eyes for examining the patient. Whereas with the indirect ophthalmoscope, I wear the instrument on my head, it has a light source, and I am going to hold this 20D lens in my hand and I am going to use it to focus the retina. And here it's a binocular instrument, so I get the opportunity to use both my eyes. Why this is important, I'll come to that later. Okay, so both these, they come as image based questions. Now the next question is that how are these two different? So you can understand that if we have two instruments, obviously each one must be having its pros and cons, right? So let us look at the direct ophthalmoscope first. Now the main USP or advantage of the direct ophthalmoscope is its magnification. So it gives you very high magnification. But as you can understand, if you increase the zoom when you're taking a photo, the area that you will cover will become much lesser. So an increased mag means a lesser area is actually covered. So that is what happens with the DO also. Because it gives you a very high magnification, the field of view is limited to the disc and the macula, that is the central retina. You cannot examine the peripheral retina with the direct ophthalmoscope. It gives you very high magnification but restricts the view to the central retina. Right? Now the optics of this instrument is such that the image that is formed is a virtual image and therefore it is an erect image. So you see the retina just the way it is. It's a virtual image and it is an erect image. Now what are the disadvantages of this instrument? One of the main disadvantages is, as I said, it limits your field of view. Another disadvantage is that if you have a hazy media, like for example if you have a cataract or you have a dense vitreous hemorrhage, or a cataract, then what will happen is the light is not strong enough, so it will not pass inside and you will not get a view of the posterior segment. So it cannot help you to examine the posterior segment if the media is not clear, meaning if there is a cataract or a vitreous hemorrhage or any other opacity in the media, then this instrument will not give you a view of the retina because the light is not very bright. Another disadvantage, because the examiner is using only one eye, that is why the perception of depth is not very good with this instrument. So that is called as non-stereoscopic view. So the depth perception with this instrument that you get is not very good because you are, as an examiner, you are using only one eye. Right? So these are the features of DO. Every one you have to memorize. This is asked every alternate year in some exam or the other. So I'll just go over this once more. The biggest advantage of the direct ophthalmoscope is its magnification. It gives you a much high mag. But the problem is that because the mag is high, the field of view is restricted. That is one disadvantage. It allows us to see only the central retina, that is the disc and the macula. Next, the light is not very bright. So if the media is hazy, like for example, if there is a cataract or a dense vitreous hemorrhage, we cannot examine the posterior segment with this instrument because the light will not pass. And because the examiner is allowed to use only one eye, the perception of depth is also not good. So the view is called as non-stereoscopic view. Okay, now let's come to the IO, the other instrument that we have. With the IO, the mag is much less. There is less magnification. Now again, exactly the opposite. If the zoom is less, you will be able to cover a larger area. So this instrument helps us to examine the retinal periphery. So anywhere, if I want to examine the periphery of the retina, I have to pick up this indirect ophthalmoscope because neither the slit lamp with 90D nor the direct ophthalmoscope is giving me a good view of the peripheral retina. So slit lamp 90D is good enough for central, DO is also good enough for central retina, but this indirect ophthalmoscope is the only instrument that allows me to evaluate the retinal periphery. The mag is less, but still it allows me to evaluate the retinal periphery. Now, the optics of this instrument is such that the image that is formed is a real image and therefore the image is inverted. Now, this is one of the I would say that it makes the learning curve of the indirect ophthalmoscope a little difficult also because you have to constantly understand that everything that you are seeing is inverted. So what you see inferior is actually superior. What you see medial is actually temporal, right? So the image that you see is actually inverted. It's a real image and it's an inverted image. So the technique of indirect ophthalmoscope is anyway a little difficult. It has a longer learning curve and also you have to constantly keep telling yourself that everything that you are seeing is actually inverted. Okay, but it has two very important advantages. It is useful if the media is hazy because the light is very bright. So even if you have a reasonably dense cataract or vitreous hemorrhage, you can still get some view of the posterior segment with this instrument. And very importantly, it allows the examiner to use both eyes. So it's a binocular instrument and therefore the depth perception is good. So the view is called as stereoscopic view. So stereoscopic view. I'll just go over this once more. Indirect ophthalmoscope. It is The magnification is less, but because the mag is less, it allows us to view up to the extreme retinal periphery. The image formed is a real image and therefore it is inverted. The two very important advantages are it is useful in hazy media because the illumination is very bright, and because it allows the examiner to use both eyes, the depth perception is good. So it gives a stereoscopic view. Okay, now these differences between DO and IDO, you have to really know it like the back of your hand. We should be able to identify these two instruments and we must know the differences. They are asked very, very, very commonly. Okay, so this is about our structural examination. So this is like the basic clinical examination that we do in ophthalmology. So we talked about the functional evaluation, that is the vision assessment, and the basic structural evaluation, that is anterior segment and posterior segment. Now there are some other special tests which are there, which I will be discussing in accordance to the individual chapters. Like I told you, perimetry I will be discussing in glaucoma, gonioscopy I will be discussing in glaucoma. So individual, some special tests are there which I will be discussing in the individual chapters. Right? Similarly, refraction and retinoscopy I will be discussing under the chapter on refraction. But this is the basic clinical examination that is done in ophthalmology. Okay, so as I said right at the beginning of this chapter, given the recent exam scenario, I think clinical examination is something which you must know properly, and this is not probably covered in that detail in our undergraduate exams, and that is why I feel that we have to do this properly for the entrance exam. So I hope your concepts are clear now. Thank you.